صباح الخير, Mr. Chairman, distinguished guests. Assalamu alaikum, Mr. Chairman, distinguished guests, my dear colleagues, ladies and gentlemen. I'm proud to start the first talk, inshallah. I'm talking about total rhinopoesis twice. I will say why, and the fate and the growth of the costochondral graft. This child came to me at the age of 2 years old with complete loss of his nose after lousy trauma. We're going to discuss it later. After reconstructing his nose, he came 15 years later on at the age of 20 or 18 years for another request to reconstruct his nose because obviously the graft that I did, it didn't grow with him. Yeah. Rhinopoesis, it means rhino, making a nose. Rhino, بناء راي. يعني term Latini, but it means nasal reconstruction. I will say just now. So at 4 months old, this poor child, his mother put him in the animal stable. He's been attacked by a vicious rat. In the countryside, they call it feral rat. He bit him and took his nose. So he needed a rhinopoesis or reconstruction. She presented him to hospital at the age of 2 years old. It's a challenging case, how to reconstruct a nose in such age. Of course, we go by the book, Skin Resurfacing, Osteocartilaginous Framework for the bone and the cartilage, and the mucus lining of the nose. And of course, there is nothing better than Sushruta flap that been invented more than 500 years ago by the Indian surgeon. And we started. I thought it would be better to expand his forehead, to use ample skin, and to minimize the scarring on the donor surface. And for the mucosal lining, I decided to take the full static unit of the nose, the full skin of the nose, as a turnover flap to do the inner side of the nose and the mucosal lining. Here is a profile. The child intraoperatively, the costochondral graft was taken piece by bone from the bone, and the rest is cartilage fixed by screws to the nasal pyramid. And you can appreciate the lateral view. I beveled the bone thing to settle at ease and to give me this angle between here and there, because it was tough a little bit to make a Columellar Strut at this start. I said I might do it later. I inserted some tubes in the new nostrils to ensure patency. Here is the flap in place, well adapted. This is the lateral view. You can appreciate the length of the nose at that time, and even the angle is less than 90 degrees. Step by step, 3 weeks later, the child is ready to section his flap. And this is the lateral view. I still insisting, look how this angle is and how long is his nose at that time. The basal view, flap is sectioned, minimal scar due to the previous expansion. A year later, at the age of 3 years old, the child is happy, the family is happy. I started to notice a little bit retraction in this angle, but I say I'll wait and see. At 4 years old, the child came like that. The mother says nothing. Here is, you can appreciate the length of the columella and the point very far. By the age of 10 years old, the child came. I started to feel retraction and withdrawal upward and shrinking of his nose. But I explained to the family, better to wait for adulthood. Years passed by. The child came alone by himself at the age of 20. He's working in the farming with his father. He stopped education. I felt he has some psychological and social problems. His nose is shrunk, and definitely we need to redo something. So I discussed it with the family, and I decided to do the same procedures and reconstruct his nose from scratch. Here is the child or the young man. I expanded the other side. Luckily, the first time I used 1/2 of the frontal flap. This time I was lucky. I still have the vessels here, so I expanded this area. And I put some plasticide to measure the exact measures of the skin flap to make it perfect from the start, because he's grown already and he needs a nice nose. And I tried, while I'm harvesting the flap, is to take part of the skin from the scalp, part of the hair from the scalp, partially hairy part of the scalp, to mimic or to simulate the hair that is inside the nostril. Anyhow, intraoperative, of course, this flap is over the supraorbital and supratrochlear. The whole static unit of the old nose that we did before, I turned it as turnover flap. You can see it here. I inserted this time only a cartilaginous graft. I didn't put bone with it because he's already matured enough and he's 20 years old. I fixed it with 2 screws, but this time I tried to be prudent, and I added a Columellar Strut. This is the flap, the mucosal flaps or the skin flap turned over after defattening or after preparing it. Here is the design where the skin I'm going to remove to make his new nose. The end of the operation here, some congestion, tubes inserted in the nostrils. 3 weeks later, the flap is ready to be repaired back in its place. Minimal scarring of the area, some edema in this area from the manipulation. The nose looks a little bit bulky, but 10 months later, the child came about 2 months ago. He looks very nice to me, very happy, and even he told me he started to go back to the college and started a university career and left his farming for his dad. The dad was not happy, but the child, I can feel he's a new person and very happy. You can see the profile here now and here. I just asked him a question. If you go somewhere else, do anybody notice anything? He said, no, just my family and the people who knew me before. Very satisfactory result. Here is a child. We reconstructed him once when he was very young, and this is the second time at his old age, at his 20 years old. Then I started to query why the growth of this reconstructed nose being affected, just to give a message later on for those who will be doing it. The forehead flap and the chondrocostal graft, obviously the skin grow with it, but just the bone stopped to grow. I started to search the literature. I went back to 1980s. I found some literature work about that, about 300 patients being revised. The nasal reconstruction constitute the majority of the patient, and some was for the TM joint. The reconstruction started from 2 years old. The centers was some in the United States, some in Australia, and some in the UK. This is the majority of the people I have found over this big period. The consensus of the authors is the osteocartilaginous rib graft is the best solution for the nasal reconstruction, nothing else. The growth pattern is unpredictable. Everybody saying that. Some advocate it grows, and others advocate it doesn't grow. That's what happened with me. The primary growth center is the osteocartilaginous junction. So this must be included in our work, if anybody reconstructing a nose in a pre-puberty. The secondary adaptive growth can go by the transitional movement. That's to say, the graft that you have put will grow with the movement of the adjacent structures, what they call functional matrix. Some even advocated, if you do it pre-puberty in Mexico and in other places in North America, they start by alloplastic materials. Once he hit puberty, they can put a definitive costochondral graft. My conclusion is, of course, the osteocartilaginous rib graft is an excellent way for nasal reconstruction as an osteocartilaginous framework. In childhood, if I do it again, or if I advise anybody from the audience, I'd rather add 10% more in the length of the graft. Later on, if you don't need it, you can readjust it. Or if the nose doesn't grow, so this extra length might save you from doing another surgery for the child later on. I believe he was lucky because not always this kind of flaps work. And I felt that when I did it when he was young, which was much easier than when I did it when he's in older age. The exact measures of the frontal flap is very important. Don't make it more, and use always a plasticide or something and measure it perfectly as if you are tailoring something. Don't say I will do it more and then I reduce it and I do several sessions. It's not always available for the people for the surgery. The Columellar Strut is very important, or L-shaped cartilaginous graft like that. I did it like that first, but then I found it's better to cut it, reduce the size of it, and I sutured it as a Columellar Strut. The last thing, use only one side of the flap, just in case you might need it. If failure happens or if you need to redo, you still have a virgin territory. Sorry. Using the supraorbital or the thing, just 1 second. Using based on the supraorbital or the supratracheal vessels. This is my conclusion. And I'd like just to remind you, by our microsurgical courses, I left this advertisement at the registration desk. Whoever interested, this is our yearly schedule. I'd like to thank everybody. Thank you very much.